Hello, everyone, and welcome to our first webinar for the critical care, the respiratory critical care fellowship. Today, we have very special webinar. I'm Professor Amr Hosseini. I'm the president of the World Institute of Critical Care and Emergency Medicine. Our first speaker today is Professor Pedro Lim from Brazil. He's going to talk about the ARS recent guidelines. Then Professor Mazen Khairallah is going to give us a fantastic presentation about individualized mechanical ventilator settings in ARDS. Our great moderators today is Dr. Khalid Maghrabi from Saudi Arabia and Professor Hana Gendi from Egypt. And our host and the organizer is Dr. Abdurrahman Abu Shadi, who is assistant professor in Manufacturing University in Egypt, who is going to moderate the session with Dr. Khalid and Dr. Hana. Just in a few minutes, I'm going to give you some heads up about our new respiratory critical care fellowship program that's going to start early 2026. It's a wholly online one-year flagship program structured as 3 modules, 16 weeks each. Every week, you will have lectures, journal club, MCQs, and clinical case scenarios. It's accredited by the American Association of Continuing Critical Education for 96 credit hours. Our first aim is to recognize our deficiencies and to work on our strength. And we are aiming to let you to master the mechanical vent and the respiratory critical care field because this field is very, very important because it deals with one of the most complex and life-threatening diseases. In this fellowship, we elect not to teach you in one-way education. We try to be very limited in lectures and reading, and we are trying to let you engage it and have more discussion, demonstration, and also adopt the new guidelines and information to your clinical practice to improve your learning curve and also to improve your retention rate. Again, 3 modules, 16 weeks each, wholly online program, and it's mainly based on dialogue, not a monologue. So every week, at the beginning of the week, you will have new materials, scientific materials, and high-quality educational contents released at 8 a.m. GMT, and all of our fellows has to submit their tasks and assignments before the end of each week. All the activities and assignments are monitored in a smart platform with a weekly quantitative and qualitative evaluation, not only based on the score, but on the engagement and the learning curve. So we are going to open the fellowship for application in a couple of days, and please keep this promo code with you, early 15. So the first 15 candidates will receive 15% discount. This promo code is going to expire in about 10 days. Again, I'm going to leave now and let Dr. Abdurrahman Abu Shadi to lead this fantastic webinar with the speaker and the moderator. But I just want to leave you with one more thing is all the activities, all the educational events that we are doing, we are aiming to improve our patients' outcome because the knowledge itself has no value except we put it in practice. And the great aim of education is not the knowledge, but the action. And thank you.
Thank you, Dr. Amr, and good day, everyone, and welcome to our first webinar of Respiratory Critical Care Fellowship, organized by the World Institute of Critical Care and Emergency Medicine. This is Abdurrahman Abu Shadi, lecturer of Critical Care Medicine, Manufacturing University, Egypt, and one of the organizing and scientific committee of the fellowship. And this webinar is the first one of multiple webinars that will be organized, inshallah, in the following weeks and months by our fellowship. And today's webinar will start with a very difficult problem, which is ARDS patient. And today we have two speakers, Dr. Mazen Khairallah from USA and Dr. Pedro Limi from Brazil. And they will give us a heavy meal in this hard topic. So prepare your coffee and be ready to participate in our interactive sessions. We have a lot of polls, so you can engage with us to enjoy learning in this difficult topic. And now please join me in welcoming our moderators, Dr. Khalid Maghrabi from Saudi Arabia and Dr. Hana El-Gendi from Egypt. Dr. Hana is a professor of anesthesia and critical care in the Faculty of Medicine in Shams University, and she is the director of the surgical ICU in Shams University. And now I will give the mic to Dr. Hana to start the webinar. Please go ahead, Dr. Hana.
Thank you, Dr. Abdurrahman, for your nice presentation. I am grateful to be with you in this scientific tutorial regarding ARDS. And it's my honor to introduce one of the distinguished speakers in mechanical ventilation, Dr. Pedro Lim Silva, PhD, Associate Professor of Physiology and Institute of Biophysics, Carlos Chagos Filho, Federal University of Rio de Janeiro, and Chief of the Laboratory of Pulmonary Investigation. And he will talk about the ARDS guidelines focusing on mechanical ventilation. Please, Dr. Pedro.
Good evening to everyone. Can you see my slides in the full screen?
Yes, Dr.
Yes?
Pedro.
Okay,
Yes.
good. So it's a great pleasure to be here to work with the World Institute of Critical Care and Emergency Medicine. It's a great pleasure to be here and honored by the invitation. So my name is Pedro Leme Silva. I'm associate professor at the Federal University of Rio de Janeiro, Brazil. I'm actually the chief of the Laboratory of Pulmonary Investigation, and we are going to talk a little bit about the ATS and the European Society for Intensive Care guidelines about ARDS, which are very recent publications, focus mainly on invasive mechanical ventilation. So I prepared an agenda that we can talk a little bit. It's the recommendations published by the European Society for Critical Intensive Care Medicine, the guidelines, the update guidelines about ARDS mechanical ventilation published by the American Thoracic Society. And then we are going to talk a little bit about the ARDS definition, the global proposal of ARDS definition, and talk a little bit about racial and ethnic minority participants in ARDS randomized clinical trials. So in order to introduce our first topic, these are the main publications that we are talking a little bit about the European Society for Intensive Care Medicine guidelines on ARDS and the update on the management of ARDS published by the American Thoracic Society. So when we construct a table comparing the European and American documents, we can see that, for example, for the low tidal volume titrated for 6 ml per kilogram per predicted body weight, both of these documents recommend has a lung protection. There is no doubt about the efficacy and the decrease in mortality since the paper published by New England in 2000. The recommendation about high versus low PEEP. Both of them, the European document recommend with so low certainty for moderate and severe ARDS, while the American document suggests high PEEP compared to low PEEP in a conditional recommendation with so low and moderate certainty. So, and if you look for the recruitment maneuvers, for example, like prolonged recruitment maneuvers, both of the documents, European and American document, they are against the use of prolonged recruitment maneuver in moderate to severe ARDS with a strong toward moderate certainty. Mainly these against this not recommendation for prolonged recruitment maneuver was guided by two main trials published in 2020, 2021 which was the ART trial and the FARLAP trial. The ART trial was conducted here in Brazil, and the FARLAP trial was conducted in Australia. So both of them showed to us a bad outcome after the implementation of this prolonged recruitment maneuvers. Going further in the comparison of these both documents, the European and American documents, we can see the proposition has a recommendation for moderate and severe ARDS. Since the publication of Papazian from the French group, they showed a reduced mortality in severe and moderate ARDS, and we can see the effects of proposition mainly during the pandemic. During the pandemic, for example, here in Brazil, a lot of people that were only talking about prone position actually performed the prone position, and they were able to see the main effect in oxygenation, but also in the decrease in the mortality rate. So prone position, which was a rescue therapy, now is actually adjunctive therapy. It should be remembered and recalled during the early ARDS. So we are going to talk about a little bit the high flow nasal oxygenation in the next slides, but I would like to focus in the neuromuscular blockers because there is a disagreement between these two documents. The European document, they suggest the neuromuscular blocker in the early severe ARDS has an adjunctive therapy, while the American document, they put the neuromuscular blockers has a conditional recommendation in early severe ARDS. So talk a little bit of these neuromuscular blockers. There was a recent publications by the group of Caroline Calfee, which did a secondary analysis of the ROSE study. They evaluated whether the early administration of neuromuscular blocker on mortality may change according to the baseline physiological and biological markers of acute lung injury, mainly the respiratory system elastance, which is the inverse of the respiratory system compliance, the ventilatory ratio, which is a ratio between the predicted and the actual CO2 levels, and the respiratory system driving pressure. Here we can see that the neuromuscular blockers was more beneficial to patients with stiff lungs. This showed to us that depending on the respiratory mechanics of these patients, the neuromuscular blocker can really improve survival in these patients. For example, they use the unity elastance, respiratory system elastance, but normalized by body weight, centiliter water divided by ml divided by kilogram, which is a very not usual unit to be used at the bedside. But if you think about a patient with 70 kilograms, this would represent a respiratory system compliance lower or equal than 35 ml per kilogram, which is a low compliance. So this study showing to us if you have patients with stiff lungs, rigid lungs, you benefit more for neuromuscular blocker in the early phase. I would say the first, second, or third day of after the ICU admissions. Interesting, they did not show any changes if we normalized by ventilatory ratio or plasma biomarkers. These plasma biomarkers we can call IL-6, the receptor of TNF-alpha, among others. So there is no change for the plasma biomarkers and ventilatory ratio. So going back to that table, comparing the European and American documents, we can go now deep in the HFNO, the high flow nasal oxygen, which is a type of non-invasive ventilation, which gets a lot of popular use, at least here in Brazil. People now know how to manage the HFNO, mainly because of the pandemic. Yeah. But the European document, they recommend has an initial strategy in acute respiratory failure to try to avoid invasive ventilation. But the American document did not discuss about the HFNO. The ATS document only focused on invasive intervention. So talking about HFNO, the most recent trial is one trial conducted here in Brazil by the BRICnet authors, which is called the Renovate Randomized Clinical Trial. It was published on JAMA this year. And these are the PICO categories of this paper. So the inclusion criteria was adults with higher than 18 years old in acute respiratory failure. And the first protocol, it was only 4 groups: hypoxemia in non-compromised, hypoxemia in immunocompromised, COPD exacerbation, and cardiogenic acute pulmonary edema. And then this study was idealized, it was thinking in 2008, 2019, and then we all know that happened the COVID-19 pandemic. And then they created a new group, the hypoxemia due to COVID-19. So actually, there were 5 subgroups in this study. The intervention was the use of HFNO, and the comparison was the non-invasive ventilation, mainly guided by facial mask. And the outcome was, the primary outcome was endotracheal intubation or death within the 7 days. And they did a non-inferiority analysis, which was defined by a posterior probability of 0.992 or greater for an odds ratio less than 1.55. So it's worth it to talk a little bit about the parameters that were adjusted in this study. The HFNO was adjusted for 30 liters per minute in COPD patients and 45 liters per minute in the other subgroups. The maximum flow used was 60 liters per minute. The FiO2 of 50% or more to achieve a pulse oximetry of 88 to 92 in COPD and 92 to 98 in the other subgroups. By using the facial mask, we can see that the inspiratory pressure was 12 to 16 and the expiratory pressure 4 in the COPD, while in the other subgroups was adjusted, inspiratory pressure was adjusted 12 to 14 and inspiratory pressure of 80. A little bit higher for the expiratory in the others, while the inspiratory pressure was a little bit higher for the COPD. So this adjustment was done according to the tolerance of the patients and the size of clinical improvement. In order to be very simple, it was a reduction in respiratory rate higher or equal to 25 breaths per minute. And the FiO2 was titrated similar to HFNO. So looking at the subgroups here, there is a column of, we call a forest plot, which is the HFNO better and the non-invasive better. If we do a frequency analysis that we are used to do with statistical softwares and regular statistical softwares, we cannot see any benefits comparing HFNO with non-invasive ventilation. There was no difference and even did not cross the non-inferiority margin, which was the objective of this randomized trial. But looking at the Bayesian hierarchic model, we can see that there are some difference. For example, for the immunocompromised patients with hypoxemia, we can see that they cross the non-inferiority margin, which is, since the non-invasive ventilation was better than HFNO, they stopped early the enrollment of these patients. Stopped for futility. While the acute pulmonary edema, for example, showed to us that HFNO was better than non-invasive ventilation, which is a very curious result, because we are used to use here in the hospital non-invasive ventilation for pulmonary edema caused by cardiogenic factors. So this study showed to us that HFNO can even be better than non-invasive ventilation. For example, in some facilities that you have a lot of HFNO catheters, maybe you can use in some patients with acute pulmonary edema. So, but this Bayesian hierarchic model is a very new, I would say, very new approach, statistical approach. But how we can really understand the Bayesian model in a basic ingredients, basic issues. So the Bayesian tries to update the hypothesis of the study, the probability of this hypothesis, according to the new evidence and data since they are available. So when you think about a study, when you have an idea of a study, you have a lot of paperwork to do until you start your study. You have the ethical committee approval, you have to recruit people, you have to train that people. You have some time lag here when you start the protocol. And then during the first year, for example, for some randomized clinical trial, you acquire the data. But for a regular randomized clinical trial, you keep acquiring the data for the second year. So the Bayesian model, a statistical model, you try to adapt your protocol. Of course, we do this by statistical approach. You adapt your protocol according to information that you gather in the first year. So this is a way to analyze your data, but it's a very feasible, very real-life form to analyze your data, because when you receive a new catheter, for example, in your ICU, and you have a lot of problems to puncture patients, but if you start to training a lot, and then you have some tips, well, I would say, some very important information that you can apply in the next patient, the future patients. So the Bayesian model, it makes free you to adapt your protocol. Maybe you did not think about this when you have the idea of the study so many years ago. So this study, the Renovate clinical trial, randomized clinical trial, showed to us that non-inferiority was confirmed in 4 of 5 patients. The HFNO was non-inferior to non-invasive ventilation, mainly in the in this to prevent intubation or death within 7 days. In that group of patients with immunocompromised with hypoxemia, HFNO was inferior and patient enrollment was suspended. What's the applicability of these studies? That HFNO could be a very good alternative to non-invasive ventilation in different clinical scenarios. We are now trying to personalize our patients. So depending on the clinical scenario, you can use better the HFNO than non-invasive ventilation, for example. And the limitations is that in some subgroups, it was observed a small sample size, and the results are more or less sensitive to statistical model, the Bayesian hierarchy. Okay, so going further for the ARDS definitions. So this is the new study, the new global definition, the proposal of new global definition for ARDS. It was published in 2024 by the group of Michael Matai, a lot of experts in the field. And going back to define ARDS is a constant challenge. Since the first publication of Ashbag and collaborators in 1967, the first document was published by the American European Consensus, which showed to us an unknown time frame. We didn't know about the insult, the respiratory insult to cause ARDS, how much time you should wait for this functional impairment. It provides some categories for the acute lung injury. There was no minimum of PEEP. There was a necessity of pulmonary arterial catheter, and the risk factors were not defined. And then in 2012, by the Berlin definition, now we have a time frame, which is 7 days. 7 days after the first insult, if you see some respiratory dysfunction, maybe you are dealing with an ARDS patient. The acute lung injury term was removed. It defined the severity. It also showed to us a minimum of PEEP, defined chest radiography, and the risk factors were also defined. And then a lot of definition by the Berlin committee. And then in 2016, there was a very important publication done in Africa, which was called the Kigali modifications. And the Kigali modification showed to us that the world is more complex and has low research facilities that maybe it's very difficult to apply the Berlin definition criteria into these low-income countries or low-income facilities. So they use the SF ratio, which is a pulse oximetry divided by the fraction of respiratory oxygen. It did not use the minimum of PEEP and use the chest radiography or the lung ultrasound, as in the context of POCUS, in order to use a very short device, a very small device that you can put in your pocket, and then it try to see some changes in the lung ultrasound, also guided by very very good definition in the vertical gradient of the thorax. And then the global definition tried to embrace the Berlin definition and the Kigali modification, which showed to us the limitation of Berlin definition. So in low research settings, the use of HFNO, because it got so much popular during the pandemic, and now the studies are showing some at least non-inferiority compared to non-invasive ventilation, and the use of lung ultrasound and the SF ratio, with some limitation that you should be aware of the use of SF ratio. So the Berlin definition was not replaced. This is important to show. This is only the category of intubated ARDS is the same as published in 2012 by the Berlin Committee. But now we have one more category, which is the no-intubated ARDS, which is a patients in the HFNO with a flow adjusted of 30 liters per minute, or even in no-invasive ventilation using a PEEP of 5 centimeters of water. So in a research limiting setting, you can use the SF ratio if it is lower than 315. Maybe you can be aware of you are dealing with ARDS patients, but you should be take care, because if you have a pulse oximetry higher than 97, you reduce a lot the accuracy of the SF ratio in order to categorize a patients with ARDS. So a lot of attention was given to pulse oximetry. But we know from previous studies shown to us a bias issue related to this pulse oximetry, mainly in Black patients. For example, this paper was published in New England 2020, which showed to us a racial bias in the pulse oximetry measurements. They showed to us that maybe the occult hypoxia can occur in Black patients compared to white patients. So here we can see the arterial oxygen saturation gathered by the blood gas machine. And then here in the x-axis, the pulse oximetry, the oxygen saturation on pulse oximetry. And if you look, for example, for this 91% of pulse oximetry oxygenation, you believe that you are dealing with a saturation of 91%. But actually, at the gasometry, at the blood gas machine, you have an arterial oxygenation saturation of 87, mainly in Black patients compared to white patients. So what this study is telling us is that you are thinking that you have a good oximetry at the pulse oximetry, but actually the patient has an occult hypoxia that are not acknowledged in the ICU. So this study has up to now more than 1,000 citations, which is a condition that we did not discuss in the last 10 or 15 years ago. And it raised a question about racial and ethnic minority patients in clinical trials. For example, this study published in Intensive Care Medicine in 2023, Papuzzi and collaborators showed to us a secondary analysis of 8 ARDS network trials and 1 PETAL network trial between 2000 and 2019 in order to assess the representation and outcomes of patients belonging to ethnic and racial minority over time. Here we can see that the participation, the representation of these minority patients, they did not change over time. Since the ARMA trial until the ROSE trial, at least you have 30% of Black people, or Hispanic, or other race. It was constant through the time. But if you look for each trial, the ARMA trial, alveolar trial, and mainly the FAC trial, we can see that depending on the therapy, you can have a different outcome in these patients. So the FAC trial showed to us, after a post-hoc analysis, showed to us that Black patients died more in a liberal fluid regimen. This was not discussed or addressed in the FAC trial. But then with a post-hoc analysis, after 10 years, the publication of the FAC trial, the authors did a post-hoc analysis, showed to us this outcome, which is a very important outcome. If you know this in advance, you can really be more conservative in your fluid regimen in the Black patients. And the mortality is reducing over time, which is a very good news. Since the ARMA trial until the ROSE and the VIOLET trial, there is a significant temporal effect in the difference of mortality between racial and ethnic minority patients and white participants. So there is an overall reduction of mortality, which is a very good news for ICU clinicians. So this study showed to us the representation of ethnic is similar or minority is similar over time. The difference in mortality rates have improved, and how we can minimize the heterogeneity by grouping ethnic and racial groups into categories and standardize the presentation of results for racial groups. This is a very important question, and I know people here, for example, in Brazil, that are doing some retrospective studies showing to us the minority heterogeneity and try to categorize this patient and see the outcomes only in this minority group. And then going to the personalized intensive care medicine. So this study was published by Papuzzi, again, for the Greek group, which is called the Greta. And it was a very nice study published in Blue Journal. So these are the PICO categories, actually PECO, because it's exposure, not intervention. So patients, they did the derivation population by the secondary analysis of 7 RCT and validated in another patient cohort, which they call Hellenic cohort. The exposure was mechanical ventilation at day 1 of ICU admission, and the comparison was in 3 categories of age. Patients higher than 80 years old, between 65 and 79, and below 65 years old. And the outcome, the primary outcome was all cause of mortality at day 90. So they gathered 4,565 patients with driving pressure at the baseline. And here is a graph associating the probability of mortality with driving pressure and age. If you see a patient with 20 or 30 years old, if we increase the driving pressure, you have a small increase in the probability of mortality, 90-day mortality. But if a patient is 80 years old, for example, if we increase the driving pressure, the rate of increase in mortality is much higher than a younger patients. This showed to us that the effects of driving pressure, 90-day mortality, depends on age. It should be called that the amount of patients per category is very different. So patients lower than 65 years old is almost 3,500, while patients higher than 80 years old is around 200 patients. So this should be acknowledged in this study. So here we can see the probability of survival according to the days following the trial enrollment. You can see patients lower If the patient is lower than 65 years old, there is no difference if a driving pressure is higher or lower than 11 centimeters of water. However, if a patient is between 65 and 79 years old or higher than 80 years old, we can really see a difference in the driving pressure with the threshold adjusted to 11 centimeters of water. Since the publication in New England 2015, that we discussed that the threshold for mortality was 15, and then after some papers showed to us it was 14, but they did not acknowledge that maybe old patients are more prone to ventilator-induced lung injury or even mortality if they are ventilated with a higher driving pressure. This study showed to us a new threshold that depends on age. So based on this RCT, they suggested the effect of driving pressure on mortality depends on age. And even a gentler ventilatory approach may be a wonder for this population. This is a very good example of personalized ventilatory therapy. So usually here in Rio, we make a joke about the soccer team. In 1970, we have a very good Brazil selection team. These guys, which is called Rivellino, was a very good midfield player. He's now 79 years old. So if Rivellino, who lives here in Rio, is admitted to the ICU, we should remember the t-shirt of Rivellino, which was 11. So we should ventilate the Rivellino with a lower than 11 centimeters of water for driving pressure. Rivellino was very nice. And this is a very good example of personalized intensive care, for example. Comparing a focal injury, very typical of ARDS, mainly pneumonia, bacterial or virus pneumonia, and then a non-focal distribution of lung injury. You can see here a very disseminated inflammation, collapse, edema, mainly because of sepsis, extrapulmonary sepsis. So how you ventilated one patient with a focal and non-focal lung injury is completely different. This was a study published by Jean-Michel Constantin by the group of Emmanuel Foutier for the Azurea Network. It's a very nice trial published in Lancet Respiratory Medicine in 2019. So if a patient has a focal lung morphology, lung injury morphology, then ventilated in volume control, tidal volume of 8 ml per kilogram, people 5 to 9, and the mandatory therapy was the prone position. While if the patient has a non-focal lung injury morphology, they were ventilated in a low tidal volume, but the mandatory therapy was the recruitment maneuver. It should be pointed out that the publication of this paper was before the ART trial and the FARLAP trial, which changed the guidelines, the recent guidelines that we talked ago. So if you look at the intention to treat population, there was no difference between a control and personalized group. But the authors showed to us that not all patients were correctly diagnosed between focal and non-focal. There was around 20% of error. And the ventilatory strategy, if you recognize in an erroneous way on focal and non-focal, for sure you are prone to ventilate in a wrong way as well. So if you look here, the personalized group, if you see the green line, compare with the dashed green line. The constant green line is the patients correctly classified, has focal and ventilated accordingly. However, if a patient has a different, has a non-focal, he has a focal misclassified and ventilated, for example, with a recruitment maneuver in a focal injury, the survival decreased a lot in these patients. Similar behavior was observed in the non-focal. So if you have a wrong classification, you ventilated wrongly, probably you have a very low survival in these patients. So if you look all of the patients that were ventilated by the protocol, which is called per protocol population, you have an effect when you compare personalized group with a control group. So the take-home message for this lecture is that the ATS and the European Society guidelines, they agree on prone position and the veno-venous ECMO, but say no to recruit maneuver. And they disagree on the use of neuromuscular blockers. The European recommend the neuromuscular blocker in the early ARDS, but the ATS did not mention or suggest with low certainty. The new definition is more sensitive and less specific. This means that you are prone to recognize a lot of patients with ARDS, but maybe they are not ARDS patients. So it's more inclusive, but maybe it can increase the type 1 error. The minority representation is stable. They are around 30% across different trials since the years of 2000. And the mortality rate is better in RCT or in ARDS, which is a very good news. And the personalized mechanical ventilation, which has a lot of reviews about narrative reviews. Now we have good examples. For example, the use of mechanical properties like respiratory system elastance, age, and lung injury morphology are very good example how to personalize mechanical ventilation according to the baseline data from your patients. So this is a picture from our group. This is my email for anyone who wants to contact me. Please feel free to ask questions, share studies. I'm happy to collaborate with the World Institute of Critical Care Medicine. This is a picture from our group here in Brazil. I would like to thank you very much, the organizer.
Thank you very much, Dr. Pedro. I think questions will go after the second part of this presentation. And I'm delighted and very pleased to introduce to you the second speaker, Dr. Mazen Khairallah. Dr. Mazen Khairallah is an infectious disease and critical care physician, intensivist. He is an associate professor at the University of North Dakota, and he's the director of Critical Care Services, Stanford Health Medical Center. Dr. Mazen, he's very well known for his contribution to the education for many years. Personally, I learned a lot from him, and he's still hosting and contributing to his with his education through his websites and through the online, through the ICU Reach and different platform. We're pleased for him to talk today about personalized ARDS, and I think personalizing care of our patients who are very heterogeneous will be an art of critical care application. So eager to hear from Mazen about this topic. Mazen.
Thank you, Khalid, for the introduction. Thank you for the invitation to share our experience and knowledge with the rest of the group through the World Institute of Critical Care and Emergency Medicine. For the sake of time, I'm going to be very direct. And the outline of my talk is going to be with few definitions and goals of mechanical ventilation, elaborate more on heterogeneity, and then briefly mention the guidelines before we go into individualized mechanical ventilation care. And if I want to define ARDS, I would say it is a syndrome, not a disease. And it is characterized by inflammation, increased vascular permeability that leads to increased lung water, that will lead to consolidation and stiff lung, that will decrease the functional lung volume. That's why we call it baby lung. And of course, it's going to impair gas exchanges. And thank you, Pedro, for the showing that the definitions have changed and there are challenges. And that is actually because of the heterogeneity of the disease. So let's start with this poll. Please scan the barcode and answer the question. In ARDS, what are the primary goals of mechanical ventilation? You can enter up to 4 words, and you can enter 1 word only. So scan it on your phone and contribute to this poll, please. So you need to type your response. Excellent. We have some saying PEEP, lung protection, oxygenation, lung safety, keep the alveoli open, address hypoxia, low tidal volume, and rest the lung. I'm going to move forward and state that it is really important to understand the difference between stress and strain. Stress is the pressure applied on the area, and that is going to result into strain, which is deformation. This is how individuals are going to accommodate to a stress. On the ventilator, stress is transpulmonary pressure, and strain is the change of volume and the shape of the alveoli. And you can see that clearly here. On the left, you will see a huge strain compared to minimal strain on the right side. You can see the change in the diameter of the alveoli on the left side compared to the right side. And goals of mechanical ventilation can actually be now broadened into not only protecting the lungs, preventing iatrogenic injury, decreasing ventilator-induced lung injury, but also protecting the diaphragm. And we need to make sure that the diaphragm is not going to be injured because of our mechanical ventilation. It is also aimed to preserve hemodynamics. You want to make sure that the venous return is not decreased and causing hypotension. And also, your ventilator settings are not affecting the right heart and causing right heart failure. Of course, you're aiming to improve gas exchanges, and you want to minimize the effects of hypoxemia and hypoxia on the tissue. At the same time, you want to prevent oxygen toxicity, and they put a question mark about that because there are conflicting literature in that regard. And the last thing is you need to relieve the excessive workload of breathing that will lead to self-induced lung injury, or what we call SILI, and at the same time, diaphragmatic injury that needs to be minimized. I can summarize the protection of the lungs, diaphragm, and right heart on this slide, and you can detail more on every single item within this slide. The next poll question: what is the most common phrase in any ARDS talk? Please scan the barcode if you did not already. This is question number 2. And let's see what is the most common phrase in any ARDS talk. And already Pedro mentioned multiple words. It is heterogeneous. We need more RCTs. Follow the guidelines. And there is no right or wrong answer, by the way. Or it depends. So we see 60% saying it is heterogeneous, and 27% would say it depends. And that is actually what we mean by heterogeneity. And let's just scan this again and contribute to this poll. start putting the answers, please. It's going to be similar to the first one. All right. So what are the identifiable subphenotypes of ARDS? So pulmonary versus extrapulmonary. All right. So I don't see that we're getting the answers we need. So let's go through them. So number one, we have spatial heterogeneity. Within the same patient, you have different areas. Some areas are collapsed, other areas are consolidated, and other areas are normal. And each one has a different PV curve. What you see on the ventilator is the global PV loop. So that's why we do not know how much of the lungs is normally ventilated, how much is collapsed, and how much is consolidated. And then we have etiological diversity or heterogeneity. We know that some cases are caused by pulmonary etiology, such as viral pneumonia, aspiration pneumonia, bacterial pneumonia. This behaves different than if it is extrapulmonary, caused by sepsis, pancreatitis, extensive burn, hemorrhage, or intra-abdominal hypertension. The cases that are pulmonary caused have higher lung compliance and likely to have focal pattern, compared to lower lung compliance, higher pleural pressure, more diffuse, and higher biomarkers in extrapulmonary. And they have variable responses to PEEP and proning. Pulmonary etiology responds more to proning compared to extrapulmonary responding to PEEP more. And then we have physiological heterogeneity. We know that the effect of ARDS vary from one patient to another, depending on the extent and location of lung injury and multiple other genetic variables. The gas exchange, the lung compliance, the ventilatory impairments are actually different. We can differentiate between recruitable subphenotype, where we have more dead space, more non-inflated areas, lower compliance of the respiratory system, lower PF ratio, and they have higher risk of death, and they benefit more from higher PEEP compared to a non-recruitable pattern. In this study, it shows also that we have biological heterogeneity. And this is based on the ARMA and the alveoli trials. They actually subclassified ARDS into two subphenotypes. Phenotype 2 has higher plasma concentration of inflammatory biomarkers, lower serum bicarbonate, higher prevalence of vasopressor use, and higher prevalence of sepsis, poor oxygenation. They benefit more from higher PEEP compared to subphenotype 1, which is hypoinflammatory, lower plasma concentration of biomarkers, better oxygenation. This form of this subphenotype benefits from lower PEEP. And this is the data that showed that mortality, ventilator-free days, and organ failure-free days are actually different between phenotype 1 and phenotype 2. If we want to continue on the biological heterogeneity, we can identify that we have biomarkers released from the epithelial injury, mainly what we call RAGE, receptors for advanced glycation end products, compared to injury on the vasculature or vascular inflammation, which is represented essentially by the angiopoietin 2. In this way, we can classify cases where they have vascular inflammation mainly compared to alveolar inflammation mainly, but most of the cases, they start in one direction and goes to the other direction. We have combined inflammation. If you have a high RAGE or receptors for advanced glycation end products, you will see it more in direct injuries compared to indirect injuries. So this is the pulmonary ARDS. Compared to higher angiopoietin 2 in indirect injury or the extra pulmonary ARDS. And you can see that those patients who had a higher level of angiopoietin 2 had higher mortality compared to the other group. And as per the previous presentation, you see the difference between diffuse ARDS and focal ARDS. And they respond differently to different modalities of therapy. The focal ARDS responds better to prone position. Diffuse ARDS responds well to alveolar recruitment strategy. In this study, they looked at the different percentages of those focal versus diffuse ARDS cases. Also, you can look at temporal heterogeneity, meaning that cases of ARDS that develop within the first 24 hours or 48 hours of ICU admission compared to ARDS that develops after 48 hours. They have a longer ICU and hospital stays in addition to higher mortality and higher scores of SAPS. And they can see here that mortality is higher, mechanical ventilation days are higher, and ICU stay days are higher in the late onset ARDS compared to the early onset ARDS within the first 48 hours of ICU admission. And you all know about the temporal heterogeneity in terms of different phases of ARDS. The ARDS goes from exudative to proliferative and then fibrotic phase, and patients in the exudative phase respond better to proning and PEEP. So we can actually classify ARDS based on the heterogeneity and the diversity, whether it is physiological, biological, morphological, or clinical, based on what we just described. And what we're trying to do is we're trying to treat ARDS with the same modalities for all those patients. It doesn't work. When we set guidelines, and that's why the guidelines are changing and they are contradicting from one country to another because it's heterogeneous syndrome. So let's just answer this. Managing ARDS feels most like following the book, you're following the guidelines, shooting in the dark, you don't know what you're doing, compared to a roller coaster, or the last one is solving a puzzle. Let's get more votes, please. I'm not seeing contributions, so let me move forward. So many clinical trials that treated patients with ARDS as unified group have failed. Different results with same modalities of treatment, same modality of treatment. We get different results depending on the population that we're treating. And from the start of the most cited study in the critical care literature, the ARMA trial that showed decreased mortality from 40% down to 31% if we just use lower tidal volume and lower pressure. And then we learned that the driving pressure is actually important. And initially, we wanted to keep that driving pressure below 15. And we defined protective lung strategy as number one, tidal volume should be 4 to 6 ml per kg of ideal body weight. Number two, we need to avoid a high plateau pressure and keeping the plateau pressure less than 30. Number three, we need to shoot for lower driving pressure, and the lower driving pressure, the better mortality. Initially, it was defined to be at 15, and now we're shooting for lower range of driving pressure, and you will see the different studies next. And the last thing is we need to use appropriate PEEP for the patient. And this is actually a very nice study summarizing the different modalities based on the severity of ARDS and where do we use each of these modalities. But I want actually to call your attention that the difficulty is actually we're dealing with dual pump system. We have the ventilator for one side. So when we set our ventilator settings, we need to avoid the ventilator-induced lung injury. But at the same time, the patient is breathing on the other side. And he's actually driving the air in with his intrathoracic pressure. And that is going to cause patient self-inflicted lung injury. And when we apply the equation of motion that you see it at the bottom here, you really need to consider the muscular pressure or the intrathoracic pressure of that is generated by the patient. And that's why we're talking about individualization. And when we say individualization, let's see what we mean by, do you use driving pressure to guide your ventilation? Yes, routinely, sometimes in select patients. I know about it, but I don't use it, not at all. Let's see better contribution, please. Yes, routinely. We have 5 votes, 7 votes. I know about it, but don't use it in 12%. Sometimes in select patients, we have 20 votes, 21 votes. So 72% voted that they use it routinely, which is great. But let me actually present the equation of motion to you this way. I removed the dynamic part of the equation. So what I have on the left side is the pressure. And we really need to include the pleural pressure in the formula. That's why I subtracted the pleural pressure from the plateau pressure. And then we have the PEEP in the system. So I subtracted these two pressures from, of course, the pleural pressure could be negative or positive, depending on the case. Minus PEEP will equal tidal volume divided by the compliance. So the first thing is we can actually personalize the tidal volume. And number two, we can individualize the pressure for the patient. Number three, the PEEP. And number four, the transpulmonary pressure. Let's just take them one by one. Personalized tidal volume. So we aim for 6 ml per kg. Is this the right thing to do for all patients? Or should we actually look at other parameters? In this study, and this is actually in rats, when they looked at the healthy lung here compared to the diseased lung, and they applied 6 ml per kg, and this is what we do, and you will see that in a healthy lung, you'll be able to expand this alveoli very nicely. So they're all going to be affected the same. However, if you take this part here, where you're including different parts of the lungs, and you apply 6 ml per kg, you're going to affect the alveoli in a different way. You're going to expand those healthy alveoli. However, you have alveoli that are diseased, collapsed, or consolidated that may not be actually open at all. And this is what is causing the atelectotrauma if we open and close, or the polytrauma that will probably end in barotrauma. And in this nice study that was done in rat, it showed that what we see on the ventilator at the macro level may not actually be the same at the alveolar level. And you can see here comparing APRV to CMV, where we're using larger tidal volume in APRV than what we see at the macro level. compared to CMV. However, at the micro level, at the alveolar level, what we see is the same tidal volume. So double the lung tidal volume in APRC, yet the same alveolar tidal volume in both modes. So actually, the tidal volume that we set on the ventilator reflects the total lung size based on the predicted body weight. And it will not consider the extent of aeration loss that we have in a single lung. And this is actually going to be very variable from one patient to another patient. In other words, the tidal value of 6 ml may still be high and injurious in some patients, and those patients would be at risk of hyperinflation, even if the tidal volume is limited to 6 ml per kg. So better if we actually look at the driving pressure, and that's what Pedro was emphasizing actually, that we need to link the tidal volume to the driving pressure. And in this study, actually, they showed that the driving pressure of 15 or lower is associated with lower mortality. And you can see the mortality continues to go lower in patients with lower driving pressure. And Pedro actually just presented very nice study showing that the age of the patient is going to be dictating the outcome based on that driving pressure. So I would say let's target the driving pressure, and let's target less than 14, better less than 11 or less than 12 at least. It's of course going to be difficult in patients with high compliance, because that driving pressure is not going to be able to drive the air, and you're going to have some issues in terms of the hypoventilation. But in the general rule is let's use the driving pressure to decide about the tidal volume that we use. The next thing is, what about the pleural pressure? Actually, we only look at the driving pressure, but we do not account for the pleural pressure. And let's just think about extrapulmonary ARDS compared to pulmonary ARDS. You need to push that diaphragm, actually. The pressure in extrapulmonary ARDS is on the lung, is not within the lung. And now we have the pleural pressure here and the plateau pressure. So plateau pressure minus pleural pressure, if the pleural pressure is negative, at that time it's going to be huge transpulmonary pressure. If it is positive, it's going to be limited. So this is actually dependent on the compliance of the lung. Is it compliance of the chest wall or compliance of the lung? And you can see here that in pulmonary ARDS, the chest wall compliance is normal. In extrapulmonary ARDS, the chest wall compliance is elevated. And you can see here that those patients with extrapulmonary ARDS benefited from PEEP much better compared to ARDS caused by pulmonary causes. And to explain this more, let's take a look on the transpulmonary. What do you mean by transpulmonary pressure? Is the difference between the airway pressure or the alveolar pressure minus the pleural pressure. And this is very important in extrapulmonary ARDS, where you have an increased pleural pressure. You need to measure the intrathoracic pressure in those patients. Let's take these 3 examples here, and let's see how the transpulmonary pressure is going to be different. If I have alveolar pressure that you see on the ventilator of 30 centimeter in the first case here, and you have a pleural pressure of 0, your transpulmonary pressure is 30. For the same patient that you see alveolar pressure of 30, if the intrathoracic pressure is minus 15, patient is exerting huge inspiratory effort, your transpulmonary pressure is going to be 45. And now when you talk about neuromuscular blockade, well, when you use neuromuscular blockade for those patients who have transpulmonary pressure of 45, is going to benefit those patients. Compared to alveolar pressure of 30 centimeter in a patient who has extra pulmonary ARDS caused by increased abdominal pressure, and the pleural pressure is plus 15. What is a transpulmonary pressure? Is 15. And you can see the difference in these three conditions. And of course, this is studied in one of the major studies, the EB-VENT-2 trial, that looked at the effect of esophageal pressure, guided positive and expiratory pressure on survival in patients with ARDS. And the study found out that when you are dealing with low Apache 2, meaning low severity of illness, this modality actually helped and showed that it's going to improve outcome. And you see here the p-value is 0.03. Compared to high Apache score, patients who are sicker, this modality did not show statistical significance. But in any way, if you target transpulmonary pressure in all patients around 0, plus minus 2, at that time you would see that there is actually improved mortality in those patients where you're keeping the transpulmonary pressure 0 to 2. And this is actually more signified in another study that shows the driving pressure of less than 15 on the right side here. You see a difference in mortality. And when you look at your obesity patients, you will see that the transpulmonary pressure that is kept above 0 is associated with higher mortality in obese patients compared to non-obese patients. And then I can show you here one example, what also the effect of intrathoracic pressure. You can see this is a real patient who's placed on 280 of tidal volume. And this is the mode is ABVCMV mode, which is PRVC, pressure regulated volume control. If the patient started to breathe, he's actually going to pull in more tidal volume than what you're aiming for. And this is actually where you would say neuromuscular blockade is going to be of help, or the measurement of esophageal pressure is going to be beneficial to you in a way that you can adjust your modality of therapy for those patients. And this is actually an example of the patient in the middle here, where this patient would have a high transpulmonary pressure injuring the lung, and this is how transpulmonary pressure is going to be represented dependent on whether you're putting the patient on volume-assisted control versus pressure-assisted control. Any inspiratory effort in patients with pressure-assisted control mode of ventilation is going to be added to that pressure that you have on the ventilator, and that is very injurious. So what we would be able to say, well, now, why don't we shoot for tidal volume determined by the transpulmonary pressure rather than driving pressure? But of course, you need an esophageal probe in order to do this. And this is an example of a patient that we had in our ICU where we had the esophageal probe in, and you can see the plateau pressure here is at 27. The pleural pressure is, or the esophageal pressure is 20.7. And the transpulmonary pressure is actually at 7, which we thought it would be very safe for the patient. And you can see that we used PEEP of 18 in order to get to this level. And then we need to look at the PEEP and try to personalize PEEP for those patients. Now, what the problem with PEEP is if you actually put it in patients who is very compliant, you're going to expand the areas of the lungs that are normal. And that's going to cause expansion or valley trauma. And you're going to be, if the PEEP is not set at an appropriate level, you're going to cause cycling, opening, and closing injury that is going to be giving you atelectasis trauma. Now, multiple studies have actually looked at whether we should use low versus high, and you know that those individual studies did not actually show results that are going to favor one modality compared to other, except in certain population. And when they put all those studies together in a meta-analysis, they found out that PEEP, higher PEEP, without recruitment maneuver, as presented by the previous talk, is actually associated with probably better mortality at rate of 99%. So when we look at the PEEP, how we're going to set it differently in different patients? Well, the first thing is actually, why don't we look at the pleural pressure? and set the beep in a way that is going to give us transpulmonary pleural pressure in expiration around 0. And this is the same patient that I just presented. This is before we adjusted the beep level. And you can see here that we had, this is end expiration now. We have the level of beep is 12. We have the pleural pressure here, esophageal pressure in expiration at 15. And you can see that transpulmonary pressure in expiration was -3. And we wanted to aim for transpulmonary pressure more than 0. So what we did is, or around 0, we increased the beep gradually and it was up to 18 centimeters of water. And at that time, we got a beep of 18 here, esophageal pressure of 17, and the transpulmonary pressure during expiration is 1.6. So that's the first individualization of beep. The second thing is actually how the beep is going to affect your compliance. You want the adequate beep. You want to recruit the lung, but you do not want to cause over distension of the normal alveoli. So the beep level that is desired is the beep level at which both over distension and atelectasis are minimized. And in this study, the subphenotypes that looked at I just presented this study, but this is only the alveoli cohort only. The previous slide was about both the ARMA and the alveoli, and you can see the different effect and different outcome of low versus high beep in phenotype 1 compared to phenotype 2. So the beep can actually be good if you're going to recruit the lung, but at the same time, you do not cause over distension, which is not good for the patient. How can we differentiate this? How can we decide what is the beep level that is not going to cause over distension? So with the current way we're practicing, there's no way I would know if the beep is going to cause more distension in certain areas of the alveoli compared to recruitment. And the ideal way is actually to do CT scan. We're learning more about using ultrasound in determining recruitment and making sure that we do not over distend. But it's actually variable experience, and we don't have enough studies actually to guide us on how we can utilize this in the best way. And you need a lot of training for those physicians in the ICU. And there's something that has been described. It is nice. We do not do it routinely unless you have a special type of ventilator, which is the EIT, electrical impedance tomography. And what we mean by that, actually, you have 2 electrodes and you just give a current. And that current is actually going to be impeded dependent on how much air do you have. You know that air does not transmit electricity. So if we have a overexpanded areas in the lungs, is going to impede the transmission of electricity, and then you can actually get a visual representation of the lungs based on how much does the lung impedes this electrical activity. There are multiple. I'm not going to detail much actually in how we do this, but you can see that there are 16 versus 32 electrodes, and current is going to be given by 2 electrodes. It's going to be received by the remaining electrodes, and then it rotates around. And this is how you get the image. And you can see here is actually put in the mid-chest area, and then you get computed tomographic axial image of the thorax. This is with 32 electrode belts. And then you look at the functional image reconstructed. Now, white means air, and black means no impedance at all. So here, actually, if you see white, it's not good. Actually, in the next one, it looks better. You have two different color coding. The Drager ventilator company uses this color coding: black for no impedance change, blue for intermediate, and that's what you need to see, and then white for the strongest impedance range change, meaning that there's too much air here. It could be a different coding rate for the highest relative impedance. This is air, green is medium, and blue is lowest relative impedance. And we say relative because it's actually compared to a control images when it's taken initially. And you can see it actually dynamically. You can see here this patient that this area is not actually represented by any bluish coloration. This is not aerated compared to this area that is aerated acceptably. In the middle here, you can see that there is expansion, more aeration in that area. And you can see that this is the same patient. This is the CT scan. This area is black here because there is no ventilation at all in this area. This is ventilated adequately. This area is expanded. It's like there's increased aeration in this area in the middle part here. Not only that, you can do also the you can do the decremental positive end expiratory pressure maneuver, where you can actually decrease the PEEP from 24 all the way down to 4, and you will be able to determine what is the ratio of areas of the lungs that are hyperventilated compared to areas of the lung that are collapsed. And you can look at the compliance. And notice here that the area of highest compliance is not necessarily the area that is giving you the minimum amount of hyperventilated and collapsed areas. So here, the PEEP should be set at around 14, compared if you're following the compliance, is going to be at 16, and we don't want to do this. I'm not going to explain this, but it gets in more details actually, and this is also detailed explanation of the same procedure. So we reached to the fact that, well, we need to identify those patients who are going to be benefiting from also proning. Are we going to personalize proning or not? Well, of course, distribution or redistribution of tidal volume towards the dorsal areas is going to be different between focal versus diffuse ARDS. It is favored more in patients with focal ARDS. And you can see here in those patients with focal ARDS, you can see how you can redistribute to the ventral areas. And you can use the same modality also to determine whether you benefited from proning or not. And you can see the impedance here, the compliance. You can see the first patient is having compliance gain, meaning that he benefited from proning, compared to the second patient here, no improvement in the compliance or no benefit from proning. This is the study that presented by Pedro, the live study. So it was nicely presented. I'm just going to quickly go over it. There is a difference in mortality only if you look at those patients who had the modalities per protocol. And as he mentioned, 20 to 21%, I believe, were misclassified. And if you see that when we misclassify our patients and use the personalized modality for those patients, we're having a difference in mortality. So it is very important to identify the right patients for the right modalities, so we don't cause this any difference in bad outcome. And the last thing that I'm going to go quickly on is the muscular pressure of the diaphragm and the respiratory muscle. We have the respiratory drive, the phrenic nerve, and the diaphragmatic functions. We need to understand how much efforts the patient is doing by, number one, assessing the respiratory center by occlusion test. Number two, electrical activity of the diaphragm. Number three, diaphragmatic activation by the ultrasound. Number four, esophageal and gastric pressures that will determine esophageal pressure time product. And lastly, inspiratory and expiratory occlusion pressures. The pressure in the first 100 milliseconds will give you an idea about the central drive. If you have a patient with increased or decreased P 0.1, which is less than minus 3.5, the normal is between minus 1.5 to minus 3.5 centimeter. If you have numbers less than minus 3.5, this is under assistance of mechanical ventilation. But on the other side, you may be given over assistance if that number is more than minus 1.5, meaning that minus 1 or 0. And the next thing is actually the diaphragmatic activity. If you have a probe in the esophagus, in NAVA mode of ventilation, you'll be able to assess that electrical activity of the diaphragm and make sure that it is within the target that you need between 10 to 20 microvolts. You can see here a patient with electrical activity of 5.5 and another patient here 17 microvolt, which is very appropriate. You can look at the diaphragm by the ultrasound, and you can assess the excursion of that diaphragm. I want to show you, this is a patient that I did myself. Actually, you can see here, he's on pressure support ventilation, and you can see how much he's contracting the diaphragm. The excursion for this patient was 7 centimeters. Anything that less than 1 centimeter is actually mini weakness. Anything more than 3 to 4 centimeters, that is huge activity of the diaphragm. And in terms of esophageal pressure time product, if you have esophageal monitor, you can look at the drop in the pressure, and you can determine the target that should be -5 to -12, so you can preserve some functions of the respiratory muscles. And if you're looking at the time pressure product, it should be between 50 and 200 microvolts. And this is just to delineate the different components of the decrease in the pressure when you take an inspiration or when the patient takes an inspiration. If you multiply the pressure by the volume, you get work of breathing, and that should be between 0.2 to 0.9 joules per liter. And the last thing is the occlusion pressure. You can actually occlude the circuit, whether in inspiration, expiration, see if the patient takes any inspiratory efforts, and measure that occlusion pressure. 2/3 of the pressure will give you the esophageal pressure if you don't have esophageal monitor. And this is just to show you on our ventilator. This is a PEEP, and this is auto PEEP, of course. Occlusion here. Look at the patient. He took inspiratory efforts, dropped the pressure from 8 to -7.7. That is a difference of 15.7 centimeter. 2/3 of that would indicate what his esophageal pressure. Those are the targets that we aim for in, in different modalities of measurement. And this is the summary of my presentation. I tried to cut it shorter because of the time constraint. I know that we've been here for an hour and a half, but you can review the different modalities here. Of course, driving pressure is less than 14 in all cases, and this is taken from one study. Now we're aiming actually the idea is the lower the driving pressure, the better the outcome. I aim for lower than 12 centimeters at least, if possible. Tidal volume can actually be a bit higher than 6 in only cases of lower recruitability, in cases with PF more than 150, in patients with focal lung morphology. You can accept between 6 and 8, otherwise it has to be 6 or less. PEEP, I would actually use higher PEEP in higher recruitability, in PF ratio of less than 150, in non-focal ARDS, and in hyperinflammatory ARDS, but better guided by different modality like the EIT or measuring mechanics. And proning would be more beneficial in recruitability, in high recruitability patients, in patients with PF ratio less than 150, and in patients with focal lung morphology. Let's end with this poll. Do you believe ARDS subphenotypes should guide ventilation strategies? Yes, focal versus diffuse. Yes, hyperinflammatory versus hypoinflammatory. Maybe in future trials, not practical in real time. And with this, I would end my presentation and giving it over to the organizers.
Thank you very much, Mazen, for this detailed lecture. And we'll open now this Q&A session. There are a few questions posted in the web, and I leave the floor for Dr. Hannah to start.
Thank you, Dr. Khalid. Question regarding Professor Dr. Pedro regarding the high flow nasal cannula. According to Renovate trial in 2024, the promising effect of high flow nasal cannula in patients with cardiogenic pulmonary edema might be due to we are using mainly the continuous positive pressure airway pressure, not the BiPAP in those patients.
Hannah, could you repeat a little, please,
Yeah.
the
In
question?
patient, sorry, Dr. Pedro. In patients with cardiogenic pulmonary edema and Renovate trial, we found that the patient had a good response to high flow nasal cannula more than the non-invasive positive pressure ventilation using CPAP or BiPAP. But would be that might be the reason why high flow nasal cannula performed better because we used CPAP, not BiPAP in non-invasive ventilation.
Yeah. When you compare the HFNO with, for example, BiPAP, you can achieve lower airway pressure when you compare the high flow nasal with BiPAP or even CPAP. But maybe the mechanisms of that improvement in this acute cardiogenic pulmonary edema is the tolerance that the patients can stay in the HFNO compare with the CPAP and BiPAP. If the patient can perform more time in the HFNO, even if a lower pressure, of course, it depends on the pulmonary edema caused by the cardiogenic factor. But if the patient can stay longer, maybe the benefits of adjunctive therapies like diuretics and cardiotonic pressors, maybe they are working together with a tolerance with this small increase in the airway pressure. HFNO can reach around 5 centimeters of water, but if implemented for a longer period, maybe the improvement relies on that period of time.
Thank you. Another question from the audience regarding the ECMO in mild to moderate ARDS patients, but with right ventricular failure. Should we consider ECMO as early as possible in this group of patients? I mean, VA ECMO.
Okay, but it's for me or for Dr. Mazen? Or both? Both?
Go ahead, Pedro.
Yeah, okay, good. So according to the guidelines, venous ECMO, it should be implemented for severe ARDS, a very low PF ratio. But the decision should be fast. It should not prolong the decision. So if the patient has a right ventricular dysfunction, maybe we should try other approach like prone position, for example, if the PF ratio is around 150 millimeters of mercury. So I would try to adjust the prone position and then see the response of this prone position, because we can use the prone position, observe the response of the patient to prone position, then think a little bit about venous ECMO. If the patient is not improving by increasing PEEP level, not improving by prone position, of course, we have to deal with venous ECMO. Maybe it's the next therapy, but depends on the PF ratio of this patient.
Okay. Thank you. Regarding the ARDS patients, to stratify and to classify those patients on invasive mechanical ventilation, it's better to use the oxygen index or oxygen saturation index better than the SF ratio.
Yes, the oxygen saturation index, they consider this index, the oxygen saturation index and the oxygen index, they consider the mean airway pressure in the formula. And under mechanical ventilation is a very important variable, the mean airway pressure. But for diagnosis reason, for diagnosis purpose, there is no at least I don't know any study that strictly compare the oxygenation saturation index with the PF or SF ratio. So maybe for a diagnosis purpose, maybe we can think in a more simple way to use PF or SF ratio. So they are still proposed as the new global definition for ARDS. But under mechanical ventilation, oxygen saturation index is very interesting because it computes the mean airway pressure.
But it will not affect the outcome of the patients regarding we use the oxygen index or oxygen saturation or the SF ratio.
No,
There's no
I
study
mean,
that
yeah,
confirms that yet.
yeah, no study confirmed it.
Yeah.
Yes.
Okay. Last question. Sorry, Dr. Pedro
That's
from the
no
audience.
problem.
Regarding the factors that determine the driving pressure values in older patients. What the factor, only age
Yeah.
or another factors
This is
in geriatric
this is
age group?
yeah, was a very interested by the Greek group. Yeah.
Mm.
And because if you think about the patients going to the ICU, usually they are older patients. And the study published in New England, which was one of the first to show to us the driving pressure was very important. It has a mixed population. Yeah, but this study published in Blue Journal showed to us that the effect of driving pressure may depend on age. Maybe what the author discussed is that you have a fragile lung structure, and maybe
Yes.
this fragile lung structure are more prone to overdistension. Going to the physiological basic, we have some kind of emphysema-like lung. It's not an emphysema, but we lose some elastic fibers. They are more prone to villi. And
So this
maybe,
like senile lung, yeah.
yes,
Yeah.
maybe they're more prone to overdistension. And maybe this study showed to us that we should be more gentle when we adjust the PEEP levels, the airway pressure. Of course, that we always want the threshold. What's the threshold? New threshold? No, but he's just showing to us that maybe you should use lower levels of driving pressure and even PEEP level as well. Now, so maybe this was one of the first study, but maybe new studies are coming to show to us the effects of other variables. Yeah.
Thank you, Dr. Pedro, for your
Okay.
very informative presentation.
Okay.
Thank
you
you.
very much.
Jay, thank you. Thank you.
There are a few questions I will direct it to Dr. Mazen. One question from Indonesia, and the question: if you have a patient with ARDS and COPD, how would you manage such patient?
Well, it's not going to change much the management. You would still provide the patient with protected lung strategy and proning if indicated. At the same time, patients with COPD would have beta agonist, and steroids would also be beneficial in both conditions. As presented by Pedro, steroids is actually recommended now. We use the protocol of dexamethasone 20 milligrams. The question in COPD whether you would use methylprednisolone, and that's what I would do. I would just like forgo the dexamethasone as we use in ARDS and use methylprednisolone in a dose of 50 milligrams twice or three times a day for the COPD exacerbation associated with ARDS.
What do you think that lower B would be more suitable for these patients?
In terms of course, those patients would have the consequences of higher PEEP in terms of hyperventilation because of it depends on the type of COPD. If it is emphysema compared to chronic bronchitis. So I would be following the same modality of determining the PEEP that is not going to cause hyperventilation. I would be more careful in those patients with COPD and emphysema with higher PEEP compared to patients with no COPD. So I would aim for lower PEEP unless it is showing you that is improving the oxygenation and not causing. If you have a modality to measure like what I mentioned with the EIT, that would be perfect application for it. You want to make sure that you're not hyperventilating or expanding the alveoli remarkably.
So esophageal probe probably would have a good application in this situation. Type.
It's going to give you an indication of transpulmonary pressure in a better way. Whenever
Okay,
it's
great.
more applicable. Actually, in our experience, we really use it almost routinely in obese patients. And we see that, we're using more PEEP on those patients, and that's actually what's been shown in the sub-analysis of in the analysis of the subgroups in the study that I mentioned. Obese patients benefit from better for management of the or measurement of the intrathoracic pressure, because you can determine how much PEEP you need to give them.
Okay, a question that I think fell in an area of your interest from Dr. Ahmed Hijazi about what your thought about APRV in ARDS.
Yeah, I'm actually a fan of using APRV. However, there is no single study except one from China that showed APRV may be associated with better outcome if it was actually initiated early, but it is small study and you cannot generalize the results of this study to other population. So far, I'm not aware of any good study that shows that APRV is going to show a better outcome in terms of management of ARDS. However, my own personal belief, I think APRV is going to provide a unique way where you can actually apply the pressure, the mean airway pressure in a better way to keep the lungs recruited, minimize the opening and closure of the alveoli because you're relying on the releases only. So I think it's a nice way of mechanical ventilation, but yet to see studies to show that it is associated with improved outcome. At the same time, you need to limit the P high. So I would continue the protective lung strategy with the P high not more than 30. Initially, when APRV released, they advised for higher P high, but I won't go for more than 30. That would actually be considered prolonged recruitment maneuver that is shown is associated with worse outcome. So I would not go higher than the lower the P high, the better.
Great. And one of the question actually here is asking about if you don't have esophageal probe, number one, is esophageal probe for the future should be recommended for routine management? And if you don't have it, what are the parameters you have to adopt in area with the low resource to get the
So I
esophageal?
showed the occlusion maneuver where you can measure the drive. If the patient is actively breathing, we can occlude the circuit, and the patient, if he takes a breath, you're going to measure how much he drops in terms of pressure. 2/3 of that pressure is the esophageal pressure or the pleural pressure. So that's the only way you can actually indirectly measure the intrathoracic pressure if you do not have esophageal probe. Now, I don't think esophageal probe is going to be routinely recommended in the future because it's also regional. You put in the probe in one area, so it does not represent the global state of the lung. Probably if you have like a probe with three areas where you can actually transmit the pressure from, when you get the pressure in 3 areas of the lungs, at that time you can get a better depiction of the distribution of the intrathoracic pressure for that single patient. Maybe in the future we can have esophageal probe with multiple electrodes.
One practical point that if you have patient in high setting or mechanical ventilation, you adjust it and then you disconnect for suctioning or care of this patient, how you bring back the patient to...
So we advise not to disconnect the circuit. So we advise for closed circuit suctioning. So please, in limited resource areas, this is very cheap. It's going to save a lot of effort. If you disconnect and the patient, by the way, the time constant is very short in ARDS, so patients can de-recruit very fast. You disconnect from the ventilator, patients de-recruited, hypoxemic, and this is one of the indications of doing recruitment maneuver. I would do gentle recruitment maneuver where I can improve that oxygenation, and this would be one of those short recruitment maneuvers that can be done in these situations to improve oxygenation, get back to the level of prior to disconnection.
Another question, probably, if you have a patient, let's say, with the trauma, and they have ARDS, how you would manage the PEEP while you have an increased intracranial pressure?
Are we talking about traumatic brain injury, or we're talking about trauma in general compared to
traumatic brain injury? A patient with intracranial hypertension, and he has ARDS. How you would manage the PEEP?
I would minimize the PEEP as much as possible because it's going to impede the venous return and it's going to increase the intracranial pressure. I would minimize the PEEP as much as possible, but at the same time, you need to keep recruitment of the lungs in a good way. Now, those patients would probably require monitoring of the ICP pressure, intracranial pressure.
Lastly, a question: if you don't have a esophageal probe and you have obese patient, what the maximum PEEP you can use?
Yeah, I'm not sure actually if there's a formula that we can use to determine how much PEEP. Neil McIntyre, once he was asked about this question, he said, get the BMI of the patient, and that would be the PEEP that allowed. I don't usually do it this way. So if the BMI is 37, you can go to a plateau pressure of 37, not the PEEP actually, the plateau pressure. So you can increase the PEEP up to the BMI level. So in other words, if BMI is 56, you can actually. However, I want to say that actually we found out that those obese patients with the esophageal probe that we use routinely on, that would require PEEP of 20, 22, 24 in order to get end expiratory transpulmonary pressure of 0. And now if you add what we recommend for driving pressure of 11 or less, you should not exceed 34, 36. That's what I would say. I would rarely exceed 34 or 36 of plateau pressure in an obese patient because I want to minimize the driving pressure. Just put in your mind, driving pressure of 11 or less is the best. If there is actually, that's why I put that poll question actually. If there's one thing that we can actually get out of this webinar, aim for lower driving pressure. Now, in an obese patient, add the PEEP, so in a way that in your mind, the driving pressure should not be more than 11.
A question from me. Where is mechanical bar fit into personalization of ARDS management?
Well, it's still in the preliminary phases, actually. We all adjust the ventilators differently from one patient to another. At the bedside, we're doing it. Like, we start the patient on PEEP, we modify it up or lower based on the response. We prone patients and we give them like first trial 16 hours. If they do not get better, we do not prone again. Flip them back and keep them. That's personalization. So I think we're doing it, but in terms of like, do we have guidelines to determine those subphenotypes very accurately and define what modalities that should be applied to those patients? Other than the live study that presented, we don't have major trials to rely on.
Okay, great. I think we went through most of the questions. Anything, Dr. Hana, you'd like to?
Thank you for you all for this esteemed meeting. Yes, very, very informative. I want to ask one question for Dr. Mazen regarding electrical impedance tomography. In our country, Egypt, till now, it's not extensively used. But up to your experience, is it beneficial to start early? Is it a promising tool in ARDS patients or not?
I do not have personal experience in it because I never used it actually. It just presented it because it's a nice way of looking at it. It actually expand our understanding of what we mean by modalities that cause harm. It's actually the ratio between collapsed versus expanded lung. I want to say that major use of EIT is from Brazil. It's been, I'm not sure if Pedro has, there's a couple of investigators actually looked into this extensively, and they are in Brazil. Pedro, do you have any comment on this?
Yes, Brazil was dealing with EIT for at least, I would say, 15 years. The development was in São Paulo by the group of Marcelo, and they implemented and did a lot of collaborations with the industrial companies. For sure, it's a very expensive equipment to be used. Maybe it should be implemented in very restricted hospitals. I would say not to be used in all the facilities, but maybe some very expert in the fields to be used. I agree with Dr. Mazen. It's a very good equipment. I deal with pigs, so I ventilated pigs with EIT, and it's a very good way to measure not only ventilation but also perfusion. So they are trying to implement the perfusion as well. If you use hypertonic saline, you can measure the perfusion and see the VQ matched region. So you have all the information that you need if you prone the patients, if you put in lateral position. It's a very illustrative and very informative equipment. But it's very expensive as well. So for low-income countries or middle-income countries, maybe we can achieve homogeneous ventilation by using more economic parameters. But if you have very sick patients, and the hospital has money to buy this equipment, it's worth, because you have your patients in your hands. You can really see the distribution of ventilation, perfusion, and all the procedures that were done in the patients.
Thank you, Dr.
Okay.
I think it's a very interesting topic, and question will not end, but I think we are approaching the second hour, and I would like to thank the speaker and hand the mic to Abdurrahman Abu Shadi.